Hello everyone. Today we're going to be talking about diagnosis of bone lesions on conventional radiography. Our objectives are to learn to diagnose bone lesions based on features on conventional radiography, location of lesion, and age of patient. On conventional radiography, we're going to be looking at lesions margins, cortical expansion, periosteal reaction, and matrix. And we're going to put all of these together to come up with a reasonable differential diagnosis when presented with a bone lesion. Being smart about bone lesions requires having good understanding of their imaging appearance and considering factors like lesion location and patient age. Let's start with the imaging appearance on conventional radiography. On conventional radiography, we'll look at things like lesion margin, lesion expansion, periosteal reaction, and matrix, and put those all together to come up with a radiographic classification. First, we'll talk about margins. Here's some examples of different lesion margins from least aggressive to most aggressive. Lesion margins are indicator of the growth rate of the lesion, and we divide those into aggressive and non-aggressive. Margins can be classified as geographic or non-geographic. The non-geographic lesions in turn are subdivided into moth-eaten and permeative. When faced with a lesion with different margins, what you want to consider is the most aggressive type of margin to help you correctly classify the lesion. The geographic lesions are the least aggressive. They're typically round or oval and are subdivided into three subtypes: sclerotic or 1A, non-sclerotic or 1B, and ill-defined or 1C. Let's talk about the different types of geographic margins. The sclerotic or 1A subtype has a very narrow zone of transition between normal yellow marrow here and the red tumor right here. As you move your mouse or your eye from the normal marrow to the tumor, it's a very abrupt change, and you can see that right here, nicely demonstrated. And the sclerotic subtype has a well-defined sclerotic margin around it. The non-sclerotic is essentially the same thing, except you just don't have that well-defined sclerotic margin around it, but it's still a very narrow zone of transition between the normal and abnormal part of the marrow. And the ill-defined geographic margin is where you start getting a less distinct transition between the normal marrow and the tumor. So as you move your eye from normal marrow to the tumor, you get into areas where you're not 100% sure if you're dealing with normal marrow or tumor. And we'll see some examples of these next. Let's start with the geographic sclerotic or 1A margin. This is a very narrow zone of transition, sclerotic rim, and these are the least aggressive type of margin and are usually benign. This is a very typical appearance of a 1A margin. This is a 10-year-old boy with a non-ossifying fibroma. You can see this very well-defined margin around this lesion, and that margin is sclerotic. Some examples of geographic sclerotic margins are non-ossifying fibromas, fibrous cortical defects, fibrous dysplasia, and Brodie's abscess. Here are some imaging examples. Again, the same non-ossifying fibroma we saw. This is the cortical desmoid, or the tug lesion of the posterior distal femur in children. And this is a patient with fibrous dysplasia. You can see this nice, well-defined margin around this lesion that's also sclerotic. Of note, there's another lesion of fibrous dysplasia over here without as well-defined sclerotic margins. The 1B or non-sclerotic geographic margins still have that nice narrow zone of transition, but they're missing that sclerotic rim, and these can be benign or aggressive. This is the prototypical 1B lesion, the giant cell tumor of bone. Here it is centered in the proximal metaphysis of the tibia with extension to the epiphysis and proximal diaphysis. And you can see this lesion has a very well-defined sharp margin distally, but no sclerosis. And this is a very typical appearance of giant cell tumor of bone. Examples include giant cell tumor of bone, aneurysmal bone cyst, osteoblastoma, low-grade chondrosarcoma, and then here's where you start getting into more aggressive lesions like Mets and myeloma. This is an ABC. You can see a 1A margin up here, well-defined sclerotic, and then well-defined non-sclerotic or 1B down here. Here's some other examples of the patient with low-grade chondrosarcoma. You can see this lesion has multiple different components of varying grade, but significantly there's areas of this lesion that have a well-defined margin but no real sclerosis. Here's an ABC, same kind of pattern again. In this case, you have well-defined sclerotic or 1A margins proximally and a well-defined non-sclerotic margin distally. And this is your punched out lesion of myeloma, where you have a very well-defined lesion with no sclerotic margin. So let's get to the 1C or ill-defined margin. These have a wider zone of transition, no sclerotic rim, and these are generally aggressive. This is a 20-year-old man with an osteosarcoma. Usually osteosarcomas have an osteoid or sclerotic matrix. We'll talk about this later, but this is just an aggressive lesion. You can see the normal trabecular bone here and here, the lesion right here, and as you move from the lesion to the normal bone, you kind of lose where the actual margin is. And this is your 1C margin. This patient also has an aggressive periosteal reaction, which we'll talk about later. Some examples of the 1C margin are early chondrosarc, early osteosarcoma, giant cell tumor of bone, brown tumor, Langerhans cell histiocytosis, osteomyelitis, and Metzen myeloma. Here's an example. It's a patient with osteomyelitis, and proximally we have a well-defined sclerotic margin or 1A margin, but distally we kind of lose where the lesion ends and the normal bone begins, so 1C margin. And here we have the post-contrast MR image in the same patient, and you have this peripherally enhancing abscess cavity inside the marrow and this extensive regional soft tissue edema. Here's a patient with a metastatic renal cell carcinoma. This part of the lesion has more of a permeative appearance. We'll talk about this later, but let's focus on the proximal and distal components that are ill-defined but geographic, or 1C. Now we get into the non-geographic. These are ill-defined fields of bone destruction. These are the more aggressive types, and these are in turn subdivided into moth-eaten or type 2 or permeative or type 3. The moth-eaten type is multiple foci of osteolysis that vary in shape and size. The cortex is relatively intact still. The non-geographic permeative margin type 3, these are very tiny holes and can result in disruption of the cortex, and these are the most aggressive types of lesions we're dealing with. This is a patient with a metastasis. You can see the moth-eaten tiny holes over here and then the more destructive appearance distally. And here's some examples of the patient with multiple myeloma, lots of tiny little holes in the distal femur, proximal tibia, and fibula. Here's a patient with breast cancer. Again, it's a very similar appearance. Same with renal cell carcinoma. This patient has a pathological fracture with comminution. This slide here is to show you the distribution of lesions and margins. 1A type margins are Brody abscess, non-ossifying fibroma, osteosteoma. But several lesions can have a range of appearances. Chondroblastoma and chondroma and fibrous dysplasia can either be 1A or 1B. ABCs and chondromyxofibromas can be any of the geographic margin types. Giant cell tumor can be 1B or 1C depending on the biological activity. And some enchondromas can have the 1C margin. Chondrosarcs, LCH, more aggressive lesions can start having the type 2 and 3 margins, but please note that some of these lesions can have a range of appearances. Specifically, Metzen myeloma can have this 1B margin as well. So just a lot going on, and not all tumors follow the rules in the book. Next, we're going to talk about the cortical expansion. Cortical expansion, as opposed to cortical destruction, implies slow growth in a lesion. These lesions are usually benign, with some exceptions. Chondrosarcomas and some metastases, namely RCC, renal cell carcinoma, and thyroid, can give you some cortical expansion without necessarily destroying the bone. And here's some examples of the patient with an aneurysmal bone cyst of the clavicle. You can see how ballooned out the clavicular cortex is. The patient with non-diagnostic biopsy, but we think it's a case of a hemangioma. A lot of ballooning of the bone. This is a patient with a chondrosarcoma, and you can see how much the cortex is expanded, but not frankly disrupted. And you can divide these into mild, moderate, and marked, and obviously there's a spectrum of behavior. And on the mild side, you have fibrous cortical defects and fibrous dysplasia. This is an example of a patient with some mild cortical expansion in a fibrous dysplasia lesion. Then you can get a little bit more expansion with non-ossifying fibromas, unicameral bone cysts, and aneurysmal bone cysts. And finally, lesions like aneurysmal bone cyst, giant cell tumor, and metastases can cause marked cortical expansion and even produce severe deformities. Here's some examples of expansile lesions. This is an aneurysmal bone cyst and a giant cell tumor of bone. Very similar, kind of soap bubbly expansile appearance. Next, we're going to talk about periosteal reaction. Periosteal reaction reflects the aggressiveness of lesions. Unfortunately, it's less specific than the other signs we're going to talk about. Here's an example of a patient with a unilamellated periosteal reaction over here. Let's talk about the anatomy of the bone briefly, just to get an idea of what the periosteum is. So you have your cortical bone, and covering it is this vascularized and innervated fibrous covering. A little cartoon of what's going on. So if you have a lesion that's confined to marrow, not disrupting the cortex and not disrupting the periosteum, as this lesion enlarges or is located eccentrically, you start eliciting a periosteal reaction. And depending on the type of lesion and how long it's been present, you can start laying down calcification. And that calcification is how we can see the periosteal reaction on conventional radiography. The types of periosteal reactions are demonstrated here. You can have a solid periosteal reaction that is very non-aggressive. And as you move towards the right here, you start getting more aggressive lesions. The buttress periosteal reaction is on the non-aggressive side. It's a variant of the solid. I've just put it here to kind of contrast it to the Codman's triangle. Let's go back and talk about these other ones, though. First, unilamellated, this is where the periosteum is elevated, and you just have one kind of layer of mineralized periosteum. Multilamellated is the same thing, just multiple times over. This is sometimes called onion skin. There's a spiculated periosteal reaction, which we'll talk about later. People talk about hair on end or sunburst. It's all essentially the same thing. And Codman's triangle is where you have periosteum elevated and tumor infiltrating deep to it. So this is a 60-year-old woman with metastatic breast cancer. You can see the solid periosteal reaction of the lateral cortex. If we zoom in right here, you can see this little cortical bump. That's solid periosteal reaction. And this ended up being a bisphosphonate-associated atypical thermal stress reaction and then a fracture that was later stabilized. This is a 42-year-old man that presented to us with pain. Sometimes the periosteal reaction is not very clearly seen. You have to window your images and then really zoom in to see it. So you can see anteriorly you have this single layer of periosteal calcification. That's the unilamellated. Posteriorly you have more than one of this, and this is a multilamellated periosteal reaction posteriorly. And here's the T2-weighted axial image of the same lesion. You can see this cortical disruption with the abscess cavity and pus spilling out into the soft tissues. You can also see this periosteal reaction right here on MRI. It doesn't have to calcify to be visible on MRI, so that's an area where MR can be helpful. Periosteum is collagen and fibrous stuff, so it's going to be dark on MRI, and you can see it right here. You can see the cortical hole right here on the MR, and you can see the cortical thinning right here on the conventional radiograph. This is a beautiful example of the sunburst or spiculated periosteal reaction in a patient with osteosarcoma. This is after several rounds of chemo. You can see the nice calcification along the Sharpie's fibers, which we'll talk about. And here it is on a T2-weighted FATSAT coronal image, and you can see the periosteum has been elevated. It's this dark line over here, but you still see some tumor or cellular material extending past that periosteum. And then you can see these low signal calcified spicules extending to the periosteum. Here's the T1 weighted image showing the same thing. T2 weighted image here, we can see the periosteum in this black line over here. It's not calcified, so we don't really see it as a shell on the X-ray. And you can see the tumor spilling out beyond that. And it's a post-contrast image showing you the periosteum again, kind of at this faint dark line over here, this spiculated periosteal reaction, and then tumor extending past the periosteum. And just a word about those Sharpie's fibers. These are these fibrous bands that connect the periosteum to the cortex. And they're named after William Sharpie, in case you're curious. And here's another aggressive periosteal reaction, APN lateral and kind of oblique radiographs. This one happened to be oblique to catch this lesion perfectly in tangent. It was a cortical lesion, and if we zoom in, we can see this cortical lesion extending into the soft tissues and periosteum, and this multilamellated Codman's triangle right here. And just to contrast this with the buttress periosteal reaction, this is a 16-year-old boy who was having pain while doing squats, and you can see this zoomed in area over here, the buttress periosteal reaction right here. It's a subtype of solid periosteal reaction, and these are generally benign. This is to contrast this again to the Codman's triangle, which is generally aggressive. Next, we're going to talk about the matrix of a lesion. The matrix is the substance in the extracellular space between tumor cells and can be helpful in identifying histology. This is where we start getting a little bit more specific with our radiographic features. The matrix can have osteoid, chondroid, or fibrous mineralization, and CT can be helpful in cases where you are in doubt. So here's an example of an osteoid matrix, here's chondroid matrix, and here's the fibrous matrix. And we'll talk about each of these in turn. Osteoid matrix can be described as fluffy and cloud-like or ivory and dense. Here's a bone island or anastosis with this ivory and dense osteoid matrix, and here's a parosteal osteosarcoma with this more fluffy and cloud-like appearance. This is another patient with paraosteal osteosarcoma, again, kind of ivory and dense in parts and fluffy and cloud-like in others. You can see the periosteal reaction over here. That's not really well seen on the conventional radiographs. Next, we're going to talk about chondroid matrix. This has been described as arcs and rings or stippled. And this is a patient with a chondroid lesion of the proximal humerus. You can see that you have a lower grade looking lesion over here. This is an enchondroma, and part of it has transformed into a chondrosarcoma. And the parts of the lesion that still have this chondroid matrix have this arcs and rings or marginal calcification here. And you can see some areas of stippled calcification as well. These calcifications are formed around the globular cartilage lobules, and we'll see that a little bit better when we look at the MR imaging for these. This is a patient with two enchondromas, one in the distal femur and one in the proximal tibia. This is the enchondroma and the proximal tibia on CT, and you can see this lobulated appearance, these stippled mineralizations over here, and then kind of more of a rings and arcs mineralization elsewhere. And just to talk about the MR appearance, like I said, these calcifications of the matrix form around these cartilage globules. And this is it on T1. You can see areas of entrapped fat within the lesion. And this is a post-contrast appearance, very typical for chondroid lesion with this peripheral and septal enhancement. This is that 15-year-old boy we saw earlier with the pain while squatting and the buttress periosteal reaction, remember? And this is your typical chondroid matrix, rings and arc calcifications within this lesion. And here it is on a post-contrast image again, this peripheral and septal enhancement, and this ended up being a periosteal chondroma, and your typical buttress periosteal reaction for benign or less aggressive lesion and rings and arcs calcifications. And just to contrast the chondroid and osteoid matrix, so the chondroid matrix tends to be more rings and arcs and globules. The osteoid tends to be more fluffy, cloud-like, and very dense. The fibrous matrix is more of a general increased attenuation or ground glass appearance. It can sometimes have dense mature mineralization, as in this case with, of fibrous dysplasia. This is the more typical ground glass appearance down here. This is a 24-year-old woman with polyostotic fibrous dysplasia, and you can see this kind of fibrous matrix ground glass appearance of pathological fracture through the lesion right here. So more ground glass and path fracture and polyostotic, so lots of lesions everywhere. A mimic of this is the Brown tumor. This is a patient with renal failure and multiple Brown tumors, including this long segment one in the humerus. And you can see the appearance can be very similar to the fibrous matrix. Just make sure you don't confuse these two. It can be difficult sometimes. All right, let's talk about location next. So location can actually be a very underappreciated and very helpful feature for narrowing down your differential. So these are 4 postoperative cases where the lesion has been completely excised, so you have zero information about what the lesion matrix look like. All you have is actually age and location in these lesions. So this is a patient with a lesion of the proximal humerus that has been curettaged and packed with bone graft material. So this is not the matrix of the lesion, obviously. This is the post-op appearance. This is a 14-year-old with a lesion that has been curettaged and grafted. You can see the outlines of the curettage cavity over here and slow incorporation of the graft material. This is a patient with a lesion in the distal posterior cortex of the femur. He's undergone hemicortical resection of the distal femur. This is an allograft that has been placed and screwed into place. And this is the patient with a lesion of the distal femur that has been curettaged and cemented. So in each case, the only clues you have are lesion location and patient age. If you can, jot down your number 1 diagnoses for each of these. Again, matrix is out because we've resected the whole lesion. Okay, so location. We can divide bones by location into long bones, flat bones, and spine. The long bones we can subdivide into epiphysis, metaphysis, or diaphysis along the longitudinal axis, or central and eccentric across the transverse axis. Some typical differentials for you. So if you have a lesion in a child that's in the proximal humerus, you want to think of UBC or ABC, unicameral or aneurysmal bone cyst. This is a patient, younger patient. The ossification center of the greater tuberosity hasn't come in, has a lucent lesion with kind of 1B or 1C margins. and mildly expansile. This is a UBC. And why not ABC? We'll talk about this a little bit later, but not much expansion and age. Some more examples of UBCs. 5-year-old boy, UBC here. 13-year-old boy, kind of on the older range for UBCs, but he has a UBC here and a pathological fracture. On MR, if the patient has had a pathological fracture, the simple cyst may not necessarily look so simple. This patient, because of the fracture, has a fluid level, which we typically associate with aneurysmal bone cyst, but because of the fracture here, we can see it in the UBC. And this is a 15-year-old with an ABC and a fracture, and a very similar appearance, but just in an older age group. Osteoid matrix in the posterior distal femur, you think of paraosteal osteosarcoma. You want to watch out for areas that are dedifferentiated. So these fluffy and dense areas are more differentiated, better differentiated osteoid, and you can start seeing dedifferentiated components if some of that osteoid starts getting eaten up. This is another patient with paraosteal osteosarcoma. You can see this dense ivory matrix back here rising from the posterior cortex of the distal femur. Very typical location for this lesion. And just to kind of give you the paraosteal, periosteal, and high-grade surface osteosarcomas on a single slide. Paraosteal is a very low-grade lesion, periosteal higher grade, and high-grade surface highest grade altogether. Posterior distal femur cortical lesion in a child. Always think of a cortical desmoid or tug lesion. These are self-resolving and are typically bilateral. Anterior cortex of the tibia, you think of adenomantinoma or osteofibrous dysplasia. You can see this kind of bubbly lesion with fibrous and more mineralized components in the anterior cortex of the tibia. This is an adamantinoma. The distinction between these two is based on age. Osteofibrous dysplasia is on the younger age range. You can see the physis is still open here. Adamantinoma is on the older age range. Osteofibrous dysplasia is typically benign. Adamantinoma is malignant. And then you have this kind of borderline case, the OFD-like adamantinoma, which is felt to be the transition state between these benign lesions and these malignant lesions. A metaepiphyseal lesion, a lesion that starts in the metaphysis, extends to the articular surface. You always want to think of giant cell tumor of bone. This is your 1B margin, typical location, giant cell tumor of bone. Make sure you're not fooled by location because Mets and myeloma can always appear anywhere. This is a much more aggressive lesion, cortical disruption, multilamellated periosteal reaction in a patient with metastatic colon cancer. Again, if you see eccentric or cortical lesions, if it's in the distal femur, you want to think of cortical desmoid. Non-ossifying fibromas are your typical eccentric lesions. They can have this kind of bubbly appearance. Flat bones in a child, always think of Ewing sarcoma. Here's the lesion right here in the scapula. Very hard to see on the x-ray sometimes. Here it is on the CT, and you can see the soft tissue component over here on the bone windows. Flat bone in an adult, you think of chondrosarcoma. Here's a lesion with ill-defined mineralization, but extending from the superior pubic ramus to the pubis. CT can be helpful. You can see these stippled calcifications of chondroid matrix within the lesion. So flat bone in an adult, think chondrosarcoma. In the epiphysis of a child, think of Brodie's abscess, Langerhans cell histiocytosis, and chondroblastoma, among some other less common lesions. Here we have a lesion in the epiphysis, another one in the metadiaphysis. This is a patient with LCH. In the metaphysis, in all age ranges, you think of metastases, then these other lesions here. Next, we're going to talk about patient age. So this is kind of a messy slide demonstrating the distribution of various lesions. Obviously, it's really hard to memorize this and put this into practice, but if you subdivide these into the other things we've talked about, it can be helpful. So an expansile and lucent lesion in a young patient, you think of UBC. In an older patient, aneurysmal bone cyst. Still older, you think of giant cell tumor, and then Mets and myeloma for the oldest age groups. And these are some examples in, say, UBC in a child, an ABC in an older child, and then giant cell tumor of bone in an adult. So very similar imaging appearance, but the age kind of helps you make the distinction. If you see a chondroid lesion, again, the age can be helpful. In the younger age group, you think of chondroblastoma. Chondromyxofibroma is a very rare lesion, so it's just here for completion, but don't really put that on your differential. And chondroma in an older age group and chondrosarcoma in the oldest age group. Location and age together can help you with chondroid lesion. If you see an epiphyseal lesion in a young patient, child or young adult, you think of chondroblastoma. Here's the chondroblastoma in the epiphysis on a T1 weighted image with a lot of edema in the surrounding bone and sometimes in the soft tissues as well. Here's another chondroblastoma, this time in a 16-year-old. You can see this lesion in the epiphysis extending to the femoral neck with lots of edema and this reactive joint effusion. In an older age group, you start thinking of clear cell chondrosarcoma. This is super uncommon, but always keep it in the back of your mind. This is a 38-year-old with this very T2 bright lesion. Chondroid lesions tend to be very T2 bright. It's in the epiphysis, so this ends up being a clear cell chondrosarcoma. CMF, again, just for completeness sake, not super common, so don't put that in your differentials. This is an enchondroma, rings and arcs mineralization, no cortical thinning, no destruction, no periosteal reaction, conventional chondrosarcoma, in a patient with a pre-existing, probably enchondroma with malignant transformation. If you have a sclerotic or dense lesion, osteosarcomas affect patients in the younger age groups. Osteomas, same age group, but obviously not as aggressive. Osteoblastomas start getting into the older age range. Parosteal osteosarcoma, median age of 30. Lymphoma and metastases in the older age groups. So here's an osteosarcoma, here's an osteoblastoma, here's a parosteal osteosarcoma. Here's osteomyelitis, not strictly a tumor, obviously, but can give you a lot of sclerosis. This is a patient with diffuse large B-cell lymphoma, increased density on the conventional radiographs. You can appreciate the soft tissue component right here. And on the CT, you can see the soft tissue component not so well on the bone window, but it's done to highlight the sclerotic nature of the lesion. This is a patient with metastatic breast cancer, multiple tiny sclerotic bone lesions. Flat bones, like we talked about, young age groups, you think of Ewing sarcoma, ABC and giant cell tumor can also affect the flat bones, chondrosarcoma in an older age group, and then always think Mets and myeloma in the older age groups. So Ewing sarcoma, which we already saw, this is a giant cell tumor of the posterior ileum in an older patient, and then a chondrosarcoma in an older patient yet. Okay, so we've talked about lesion appearance on conventional radiography, location, and age, and hopefully you guys are now super smart when it comes to bone lesions. All right, so let's take a look at this, taking into account location and patient age. So a lesion in the proximal diaphysis of the humerus in a young patient. This is a UBC. This is what it looked like prior to surgery. This is after surgery. This is a 14-year-old, similar location. This is an ABC. This is what it looked like prior to surgery. It's a 21-year-old with a distal femoral cortical lesion that required a hemicortical resection. It's a periosteal osteosarcoma. You can see the soft tissue component here. This fluffy osteoid matrix here, not the most typical osteoid matrix, but again, there's a lot of variation in what these things look like. And then this is a lesion in the metaphysis that's extended to the epiphysis, middle age, and this is a giant cell tumor of bone, and this is what it looked like prior to surgery. If you have any questions, get in touch with me after the lecture. Thank you very much.